Hello, welcome to today's session. This telehealth series is presented by the Now New Mexico Quality Improvement Initiative. This initiative focuses on optimizing care for neonates at risk of opiate withdrawal syndrome. This 12-part curriculum is designed to give providers, nurses, care coordinators, and community members content-specific training and education with opportunities for case consultations around this focus. Today we have Dr. Mary Beth Sutter, who's an assistant professor of family medicine at the UNM School of Medicine. Her interests are in group prenatal care for women struggling with substance abuse in pregnancy and neonatal opiate withdrawal syndrome. So thank you for being here, Dr. Sutter.
Thank you. So today I'll be discussing perinatal substance use, epidemiology, myths, and facts. And this is a very important topic to me. I'm one of the family doctors that staffs the Milagro Prenatal Substance Use Clinic at University of New Mexico. And also I take care of many babies affected by neonatal opiate withdrawal in the newborn nursery and the intermediate care nursery at UNM Hospital. The objectives of my discussion today are, number one, to talk about the scope of the problem of substance use in pregnancy in the United States as a whole and in New Mexico specifically. We'll also briefly review various substances and effects during pregnancy, and we'll discuss main myths about perinatal substance use in pregnancy. So to start off, SAMHSA is our national organization for substance abuse and mental health, and they publish every year a survey on self-reported substance use around the country. And this is the main tool that we have to know how much and which people are using drugs in America. In 2013, they estimated that about 5.4% of pregnant women were using illicit drugs. This number varied by age, so the rate was higher in those ages 15 to 17, and also in those ages 18 to 25, and those are primarily the women having babies. The use also varied greatly by trimester, so we saw that in the first trimester, use could be as high as 8.9%. A lot of women were able to come off of drugs in the second trimester down to 5.3%, and in the third trimester, only 1.9% were still using. Marijuana was the most common drug that was reported in this survey, and prescription opiates were the second most common. And then other illicit drugs like heroin, methamphetamines, and cocaine came in on a lower 2%. The problem with this survey is that it was done by mail and by phone call. So in order to even participate in it, you had to have a permanent address and a landline phone number. So it probably does not represent the true scope of the problem in the US. There's also even more problems with self-report. So determining the actual rate of substance use in pregnancy in particular is very difficult. There is a sense of stigmatization against women that are using substances in pregnancy, and there are several fears. So removal of children by child protective service organizations. There's a risk of incarceration and other legal repercussions. So women may not actually disclose what they're doing. In some studies that have been done, there is a correlation with urine drug metabolite screening that only reached about 60%. And they also found that women tended to say they were using earlier in pregnancy than their drug screens would indicate. So possibly trying to appear more socially acceptable by using drugs earlier when maybe they didn't know they were pregnant or weren't visibly pregnant. If we try to look at reproductive age women as a proxy, the use in that age group, so ages 15 to 44, was 12.1%, so more than double the rate reported for pregnancy. And that was an increase from 10.7% back in 2011. The most rapid rise is in the use of marijuana and prescription opiates. There's also some thought that women may progress more quickly in cycles of addiction than men due to hormonal changes. And we do know that prescription opiates are readily available in the community, and they are frequently given to young women of reproductive age without a second thought, perhaps from a car accident, from a cesarean section recovery, chronic back pain. These are all common problems that we see out in the community. And this, unfortunately, due to the highly addictive nature of prescription opiates, can start a vicious cycle. If we look at New Mexico specifically, there was a survey back in 2012 trying to determine, again, the rate of substance abuse by self-report. We are the highest drug overdose death rate in the nation, second highest after West Virginia. Our highest rate is in Rio Arriba County, and those overdose deaths are primarily from prescription opiates and heroin. In New Mexico, they surveyed and asked what was the rate of last month drug use, and in adults that was up to 24%. In certain counties like Bernalillo County and also Rio Arriba County, that rate was over 30%. And in the US as a whole, it's only 21%. So we are disproportionately affected by this problem in New Mexico. Again, the data for pregnancy are really difficult to find, in particular for New Mexico. We do know that as part of our Milagro clinic at UNM, which cares for women affected by substance use and pregnancy, we've had 180 births per year for the past 2 years, and we find our numbers are increasing every year. And those are just women that are coming for treatment and that are able to come to Albuquerque. So we still have the whole rest of the state to consider. One of the problems with substance use and pregnancy is the concept of criminalization of women as a solution to this problem. So 18 states in America consider substance use and pregnancy to be a form of child abuse. 3 states would consider it grounds for civil commitments, and 1 state considers it to be an actual assault on a child. So there's good reasons for women not to come forward to report their use or to seek care. We do require reporting of suspected substance abuse in pregnancy via the Federal Child Abuse Prevention and Treatment Act, or CAPTA, and that's a national law. However, it's interpreted differently in every state. So typically at University of New Mexico, we will report women who are using illicit substances at the time of birth, but we do not choose to report women that are stable on medication-assisted treatment with methadone or buprenorphine. That, however, varies across the country. Incarceration is also not uncommon, especially in our state. Many of our patients report they were incarcerated at least for a few days, sometimes weeks or months. There is a trend to try to get women to step down levels of care, for example, through women's recovery or residential treatment. And it's rare to deliver in custody, but it does happen a few times per year. Legal consequences, it's important to note, often target low-income women and women of color. And in multiple studies, incarceration and other legal repercussions have failed to improve either patient engagement or outcomes for mothers and babies. So the policies are discriminatory and they are not helpful. Now let's go through all the various substances that can be used in pregnancy and their effects. So opioids are the most commonly used substance in New Mexico. Birth defects are likely rare. There are some studies that show weak associations, but we think these are probably due to confounding, so other substances used or other factors. It can, however, cause a withdrawal syndrome in the neonate at birth, and that is the focus of this project. We know that withdrawal and untreated opiate dependence in moms is also associated with poor perinatal outcomes. And these can include things like intrauterine growth restriction, which can be a cause for preterm birth, also can be a cause of intrauterine fetal demise and preterm labor. And these are thought to be primarily due to a chronic cycle of withdrawal and chronic stress in the mother and in the placental environment. We do know that medication-assisted treatment, so that's treatment with methadone or buprenorphine, does improve outcomes for moms and babies. And medication-assisted treatment will be the subject of one of our talks in the future in great detail. Prescription opiates are more accessible and more socially acceptable than illicit drugs. are readily available in the community. They can be a gateway drug to heroin, as we discussed previously. It's not an uncommon story to hear of a woman who is addicted to oxycodone or another prescription opiate, gets cut off from their prescriber, is unable to obtain the prescription in the community illicitly because it's too expensive, and turns to heroin, which is readily available and cheap. We do know that continuous heavy use of prescription opiates in pregnancy can result in neonatal opiate withdrawal at birth. So the exposure for the baby, while it may be a different drug and it may be legal, medically is the same for the baby at birth. Episodic light use is probably okay. So that would be things like a few weeks use of medicines after having surgery or after having a stent placement or a lithotripsy, something like that. Methamphetamines, when we look at that, 7.2% of pregnant women reported ever having used methamphetamine. And we do know that it's the primary drug of abuse in about a quarter of women who seek treatment. Unfortunately, there's no pharmacologic treatment for methamphetamine. There is unlikely to be any risk of fetal anomalies. There is definitely an increased risk of perinatal complications. And these are all due to vasospasms, so blood vessels constricting abruptly in the mom and in the placenta. So gestational hypertension and preeclampsia are common. Intrauterine fetal demise is possible. Placental abruption, which can lead to massive hemorrhage in the mother and the baby. Preterm birth and low birth weight, and even neonatal death. There is no treatment available, so the mainstay would be counseling and residential treatment programs where women can receive help. We do commonly see methamphetamine as part of polysubstance abuse, especially in our heroin users in our Milagro clinic population. Cocaine, similarly to methamphetamine, is another stimulant. It may increase the risk of anomalies in babies, but there's no known pattern that this follows, and there's not a neonatal cocaine syndrome. There are an increased risk of perinatal complications, again due to vasospasm, so preterm birth and low birth weight, growth restriction, hypertensive disorders of pregnancy and preeclampsia, and placental infarcts and hemorrhages. And again, there's no treatments available for mothers or for babies. The mainstay of therapy would be counseling. Luckily, cocaine is pretty rare in New Mexico. Marijuana is increasingly common and available and legal, and will be an important drug to consider over the next several years. Right now, there's not a lot of data. There is no known teratogenicity. There's also no known increased risk of preterm birth or mortality in babies. It can take 30 days for complete excretion of the drug into the urine in women who are using chronically, and that is especially compounded in pregnancy due to high fat stores. There are unclear effects in the fetus, so sometimes there's confounding in studies. Women are also using tobacco in particular or other drugs. There's possible risks of school problems in children, so decreased attention span and behavioral problems, although those are not completely proven. So we do not recommend that there's any safe level of marijuana during pregnancy or during lactation, again, because of the concentration of the drug in fat, so breast milk being particularly fatty. And there's no pharmacologic treatments for moms or babies. We do commonly see marijuana in our population, again, as part of polysubstance abuse. We often take a harm reduction standpoint on it, and that is something I think over the next several years that there needs to be a lot more research on, especially in pregnancy. Benzodiazepines are available as pills illicitly in the community and also via prescription. There's mixed data on whether or not they're teratogenic, but it's probably low. The use seems to be increasing. It's often part of a polysubstance abuse picture. So women medicating themselves to try to get off of substances with benzodiazepines. It's also not uncommon to see prescription given to reproductive age women for anxiety disorders or post-traumatic stress disorder, which is common in our population due to adverse childhood events and other traumas in the past. Withdrawal from benzodiazepines is life-threatening for the mom and the baby in long-term heavy users. And so mothers are recommended to be tapered either inpatient or outpatient over a long period of time with a long-acting agent like clonazepam. And this is really a case-by-case decision-making basis that should involve psychiatry as a consultant. We find that benzodiazepine abuse is very resistant to treatment. Often women have been on these drugs for years to try to treat mental illness, and it's extremely difficult to get them off of them during pregnancy, and they often relapse back to them after birth. Alcohol is the only substance with known teratogenicity and causes fetal alcohol spectrum disorder, which represents a wide range of physical, mental, and behavioral disabilities. Currently, there's no consensus as to how much or if any alcohol is safe and what part of pregnancy the risk might be the highest. So we cannot recommend any alcohol use during pregnancy at the moment. Pharmacologic therapies for alcohol abuse are available. However, they're all category C, meaning there's no information on them in pregnancy, and so they're typically not used. Acute alcohol withdrawal is rare, but when it occurs, needs to be treated inpatient due to the risk of seizures and serious morbidity. And that's often done with a benzodiazepine taper. Sorry. Tobacco has no known teratogenicity, but it does have risk of adverse perinatal outcomes such as intrauterine growth restriction and preterm birth. We do know that quitting in the first trimester reduces the risk of these significantly. We often see tobacco in very light use, again, as part of polysubstance abuse in our women, and a lot of women actually are able to quit prior to birth in our population. Nicotine replacement therapy is an option in pregnancy, so that could be the patch, the gum, lozenges, all are fine. Bupropion or Wellbutrin is also an option. We're not currently recommending Chantix because there's not data, again, it's category C. E-cigarettes are definitely used in the community. There's no data on them yet. We often consider this to be part of a harm reduction conversation with a patient. So if that is something that a woman is using to cope with anxiety and getting off of other drugs, then maybe that's okay. Okay, and now we'll go through a couple of myths about substance use in pregnancy. These are things that I hear commonly in my practice from patients, from families, from other health professionals, and that are extremely important to dispel in order to get the most fair and equal care for our women. So myth number one, substance use is a moral failing. And of course, this is not true. Substance abuse is a chronic illness. So just like diabetes, just like hypertension, it requires a daily conceded effort in order to recover. So relapse and remission are common and happen on and off throughout a lifetime. Substance use is highly intertwined with history of adverse childhood events and other traumas. And that is pervasive in New Mexico as well, unfortunately. Treatment with medication-assisted treatment, though, reduces relapse and promotes sustained remission. Myth number two, it's best for pregnant women to cut off all substances cold turkey. Something I hear a lot from families. And even actually other rehab centers. So this is definitely false. Medication-assisted therapy with either methadone or buprenorphine, trade name Subutex, are the gold standard of care in pregnancy. We think that withdrawal is dangerous, and so it is not recommended. There was actually an interesting recent study where they looked at women who were forced basically to come off cold turkey because they were incarcerated. And they saw relatively low rates of preterm birth and miscarriage and things like that. However, they failed to look into what happened to those women after they were released, and the majority of women will relapse, and so therefore will be exposed to high-risk health behaviors, exposing themselves to needle sharing, Hep C, HIV, this cycle of withdrawal and relapse, and that is not good for a pregnancy. So we recommend medication-assisted therapy to avoid those consequences. Myth number 3, heroin causes birth defects. This is something that women actually ask me about quite often, and may stem from partly a guilt type picture on their part of having used heroin in pregnancy. A lot of people will enter care like almost certain that they've hurt their baby in some way and feeling very bad about that. Heroin does not cause birth defects, however. The only substance that we know definitely does is alcohol. Opiates in pregnancy do, however, put babies at risk for neonatal opiate withdrawal, which is a large problem and the focus of our initiative. Myth number 4, methadone and buprenorphine are just replacing one addiction for another. So this is another common thought in the community, also sometimes touted by organizations that are trying to help women recover. This is false. Medication-assisted treatment is extremely important and extremely valuable because of the relapse prevention and avoiding those high-risk behaviors that are associated with relapse. We know that medication-assisted therapy promotes sustained remission in patients. So it is not a drug they're using to get high. It's extremely difficult to get high on methadone, not possible scientifically on buprenorphine due to its agonist and antagonist properties. So this is a solution just like you would take a high blood pressure medication for your hypertension. This is a medication you're taking as chronic therapy for a chronic illness. Pregnancy and the postpartum period are also extremely stressful times. So a lot of these women are becoming new mothers, they're changing households, they're cutting ties with their only friends they've had due to drug involvement. They may or may not be with the father of the baby, experiencing domestic violence. So this is a really high risk time, and it's extremely important to have the ability to depend on that medication assisted therapy during that time. Myth number 5, breastfeeding is not recommended while on methadone or buprenorphine. I've heard this from many people, including lactation consultants. Also false. Breastfeeding is actually encouraged for women who are stable on medication-assisted treatment. So, for example, a methadone patient who's having their second or third baby has been in methadone treatment the entire time. Someone who presented very early in care, got on buprenorphine, and has been clean the rest of pregnancy. Those women are highly encouraged to breastfeed because breastfeeding helps reduce the severity of withdrawal in babies and the likelihood that babies need medication from neonatal opiate withdrawal. It also is an amazing bonding tool, which can be really protective for women during that high-risk period when they're prone to relapse. MAT medications we do not think pass in breast milk in any significant quantity that would alleviate or would cause withdrawal in babies. And that's also something that's out there in the community, that the methadone's coming through the breast milk helping their baby. It's actually the comfort and the bonding of breastfeeding that helps babies, we think, and not the medication itself. Myth number 6. All babies who are exposed to opioids in pregnancy withdraw and are hospitalized. So this is also false. The withdrawal rates vary greatly for methadone or buprenorphine, and when looking at national studies, the percentages are all over the board, anywhere from about 25% to 75%. What we tend to see at UNM is a relatively low rate, about a third in our buprenorphine moms, and about 40 or 50% actually only in methadone patients. And that is because we have such a great, strong rooming in program. So rooming in, breastfeeding will reduce the risk of withdrawal in babies. So while having quiet, calm environments, We also think there might be a genetic component to withdrawal or the influence of other medications mom might have been taking. So polysubstance abuse, tobacco in particular, psychotropic agents that the mom might be on. And these things will all be looked at in further detail in our future presentations. So some babies go home at 4 days and are fine, and they do not ever experience withdrawal that needs meds. Myth number 7, if you have hepatitis C, you have to get a cesarean section and you cannot breastfeed. Hepatitis C is very common amongst our population. About half of our patients in Milagro Clinic probably have hep C. Vaginal birth is actually preferred for women with hepatitis C regardless of a mom's viral load. So different than, for example, HIV. Breastfeeding is also supported in hepatitis C as long as there's no possibility of blood transmission. So hepatitis C viral particles are not present in breast milk. They are present in blood. So if a mom has bad nipple trauma, we recommend pumping and dumping until that's healed. And myth number 8, mothers on methadone and buprenorphine cannot have medicine for pain control in labor. So this is something that I hear often as a fear from women. And again, I think high relates to feelings of guilt that they don't deserve to have pain medication during delivery because it's their penance for having done drugs in pregnancy or something like that. It's a vicious cycle that sometimes is present. Labor can be particularly hard, I should say, for women who are struggling with substance abuse because a lot of them have had past traumas and especially sexual trauma. Mm-hmm. So it's extremely important to dispel this myth early on and offer as much support as possible. Nitrous oxide, IV opiates, epidurals, all of it is safe for women on medication-assisted therapy on top of that medicine. Some therapies, though, are not as effective, and that's because there's a level of dependence. So a woman might need more doses of IV fentanyl than the average person. And that's it. So conclusions of the talk. Substance abuse is increasingly common, and it's also underreported in pregnancy. Alcohol can cause birth defects. Opioids can cause neonatal withdrawal syndrome. Myths are pervasive among the general population and also the healthcare community. And dispelling these myths makes a big difference for women in terms of equal care. And pregnancy and parenting can be a time of high motivation for change and a chance to break the cycle. So this work is important and it's valuable. Thank you.
Do you have any questions?
I don't have any questions.
Excellent talk. Thank you for being here.
Great. Thank you so much.